Okay, so we are talking about addiction today, and there was an advanced organizer that went along with addiction. So first off, I just want to know if you had any questions specifically about the advanced organizer. If you had any issues with any of the um, terms, or looking at the table in the textbook that talked about the medications that are used in alcohol withdrawal delirium, because you do want to be familiar with those. Anything there? How about question 4? How do you, what's the relationship between alcohol levels and effects in a non-drinker? And how do we apply that when somebody drinks regularly? So somebody answer that one for me.
The tolerance, so I have 8.08, and a non-drinker is anywhere from 1 to 6 drinks, and it's legally intoxicated, whereas a regular drinker or somebody who drinks every day, they may need more alcohol to achieve a level of intoxication due to tolerance.
Sure. So if you look at page, very good. If you look at page 304 there, it talks about how many drinks it takes to get to what level, and then it talks about the effects. But that's where I wanted you to understand that's a non-tolerant person. So it's not going to line up like that if the person drinks regularly. They'll have tolerance, and so what you'll see is their effects are much lower than what you would expect from their blood alcohol level. And so that is an important concept to understand when you're looking at lab results. Okay. I wanted you to take a look at that. And then the last piece was just looking at the table. I think the page numbers might have been wrong in there, but it was just looking at the table that we're going to go over today. So addictive disorders, there's some different terminology that we want to make sure that we're understanding. So abuse is the habitual use of a substance that falls outside of medically necessary or social acceptance for the single purpose of altering one's mood, emotion, or state of consciousness. So that's important to keep in mind, because sometimes people get confused and think that the terms, like if you have tolerance to something, that automatically means that you have an abuse issue, or you have you're maybe not using a substance correctly. And so we just want to make sure that we're understanding what the actual definition is of abuse. And we'll get into some of those other terms again that you looked at. So when we talk about the addiction, this is compulsive behavior, cravings, chronic relapsing disorder. So when we talk about those 4 C's that go along with addiction, it's cravings to compulsion, chronic relapsing brain disorder, and cognitive impairment. So that was craving to compulsion, chronic relapsing brain disorder, and cognitive impairment. So there's lots of different substance use disorders that you can see somebody diagnosed with. Now, we are not talking about all of them, we're talking about most of them, but anything from alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedative hypnotics, anxiolytics, stimulants, tobacco. We're not talking about tobacco or caffeine in this class, although I could probably be a case study for caffeine addiction, but we're not going to go through every one of those, but most of them. And then they're categorized as mild, moderate, or severe. Now, I do want you to know that the information that we're covering, especially the information in the table at the end of the section, is NCLEX blueprinted material. It's very specific in the NCLEX that they want you to know what somebody looks like when they are intoxicated, overdosed, withdrawing, what the treatments are. So all of that is very specific in NCLEX, okay? And this is really the only time that we cover it in class. So the etiologies, there's a lot of biological factors or genetics. They believe that there's some biochemical factors and developmental influences, which we'll go through here. And then there's also personality factors, social learning and conditioning, which is another one that we're going to talk about, and cultural and ethnic influences. So biological is really the effects on the neurotransmitters. And basically, people get pleasure from dopamine binding to the synaptic neuron in excess. So I'm going to kind of read what's here, but I'm going to explain it afterwards, okay? The body regulates by making less dopamine or decreasing receptors. So more drug is then required to make more dopamine to make the levels high or even normal, which begins a cycle. So it's a lot of words to basically say that in the brain, we know that we have the synapse, the space between the neurons, okay? And dopamine travels from a presynaptic neuron to a postsynaptic neuron across that synapse. So what happens is it, it comes out and then it has to attach to a receptor on that postsynaptic neuron, and then that causes a response. So we think of dopamine as our pleasure neurotransmitter. So when somebody gives you a hug, you get a little release of dopamine, hopefully. When you get a good grade, you get a little release of dopamine. Have sex, release the dopamine, stuff like that. So anything that is pleasurable is going to release dopamine. So what happens is when you take a drug, these drugs cause this artificial, like a super high release of dopamine, something that your body naturally would not release. Okay, it's an amount because it's just causing that to flood out. Okay. So what happens is there's this really high dopamine from the first use of that drug, and the body's like, whoa, we gotta downregulate. We have got to get back to homeostasis. This is way too much. So what will happen is the presynaptic neurons will actually either or both, they will stop producing as much dopamine, and or the postsynaptic neurons will kill off some of the receptors so that even if all that dopamine is available, it can't actually do anything in that postsynaptic neuron. So then what happens is, so the person takes the same dose again. Well, it doesn't have the same effect anymore because either the presynaptic neuron's not making as much dopamine and or the postsynaptic neuron isn't accepting it. So what's the person do? They increase the amount of the drug that they take. And the same thing happens. So the body keeps down regulating to the point where when that person gets a hug, now the presynaptic neuron doesn't make dopamine like it did. So it's not available to be released, or there's so few receptors that that person doesn't get anything from that hug. And so that's why people will say that I can't even feel normal without the drug, that they require the drug just to feel normal anymore. It's not even about the high. So I'm going to look to see if that makes sense. So give me some head shakes if that makes sense too, if I need to go over it. Okay, good deal. Okay, so, and that's why then it's cyclic. So personality disorders in general tend to go along with substance abuse, but also there's some very specific kinds of characteristics. So somebody who has a decrease in frustration for tolerance, a decrease in tolerance for frustration or tolerance to pain, are more impulsive, low self-esteem, or tend to be risk takers. culturally, actually the Asian population tends to have a decrease in substance or particularly alcohol abuse, because some people of Asian descent lack an enzyme that helps to break down alcohol. And so what can happen is that they actually can have a response to it, a very negative response where they flush and get palpitations, really just don't feel well. It's almost like a natural aversion response to alcohol, which there's actually medications that we give to cause this response. Okay, so intoxication is a physical or mental state of exhilaration and emotional frenzy or lethargy and stupor. So by definition, it is a reversible substance specific syndrome. So it depends on which substance the person is on as to how they're going to react. Now, dependence includes tolerance and withdrawal. But what we need to understand is that tolerance and withdrawal are normal when using any substance. Okay. And just because somebody is dependent on a substance doesn't mean that they're addicted to it. Those are two different concepts. So, I mean, it would be like saying that somebody is dependent, because somebody is dependent on their glucophage or their metformin or something along those lines, that they are addicted to it. And that's just not, that's just not the case. Or their blood pressure medication. So tolerance is where we need an increased amount or more frequent dosing for the same effect. Need the increased amount or more frequent dosing for the same effect. Withdrawal is physiologic and mental readjustment that accompanies the discontinuation of a substance. So often the physiologic part, can take days, a week. It's the mental part of the addiction that takes a lot longer to treat. When we look at dynamics of substance-related disorders, there are definitely some family considerations that go on. And so you probably heard the terms enabling or codependence. So we just want to make sure that we understand what those actually mean. And enabling is helping the chemically dependent individual. So helping the chemically dependent individual avoid experiencing consequences of drinking or drug use. So avoid experiencing consequences of drinking or drug use. And it's one behavioral component of the codependent role. So this is, enabling it is helping someone not experience the consequences of their decisions. Okay. And so people think that maybe that they're helping the person, but in fact it's enabling them, it's allowing them to continue on with their substance use without having the consequences, those natural consequences that help us make better decisions. So again, this is part of the codependent role. So codependence is over responsible. Being over responsible. It's a combination of maladaptive thoughts, feelings, behaviors, and attitudes that prevent the person from living a full and satisfying life. So it's being over responsible, a combination of maladaptive thoughts, feelings, behaviors, and attitudes that prevent the person from living a full and satisfying life. So this is not the person who's using, this is their family member. And Can you see how somebody can have the thoughts, behaviors, attitudes where they feel so responsible for their son, their daughter, their significant other, their parent? They feel so responsible for that person that they kind of lose a sense of themselves. They're no longer, a regular functioning person. They've kind of built everything to revolve around being responsible for that person who's using substances. Okay. So often people can actually go into treatment like Al-Anon. So those can go to AA that are using substances, but Al-Anon is for family members, and that can actually help them so they're not part of that codependence. So cultural considerations, we talked about some specific populations already, but we do need to recognize that healthcare workers are actually at high risk for substance use. They tend to have an increased dependency on opiates and benzodiazepines. Opiates and benzodiazepines. Now, I believe that we talked about this a little bit in fundamentals of what to do if you have or if you discover somebody who is impaired. However, I just want to bring that back is that, remember, we follow our chain of command. It's just that when it's a legal issue like this, you skip the person that's involved. So this person that you suspect is using a substance or that you know is using a substance, you don't go to them in this chain of command. You go to your immediate supervisor first. And then who remembers what the most important thing is when you suspect a coworker is under the influence?
Patient safety.
What was it?
Patient safety.
Patient safety, absolutely. So that's our number one concern. And just, you have to think about in different scenarios that if the person that you think is using a substance is coming out of a patient room, then we would go to that patient room first, right? That would be the first thing that we would want to do. If the person is coming out of the med room and we see them, or they're in the nurse station, we see them, we want to report first so we can keep them from the patients. Okay, so just keep that in mind. We also want to make sure that we're not enabling as well. So sometimes you can enable a coworker, you punch them in, cover up for them, lie for them, whatever. We cannot enable drug use, because then you become just as responsible for the outcomes that happen as that person. Okay, so the next piece here are the effects on the body. So this is specific to alcohol. Okay, so these are alcohol's effects on the body. And I'm just going to go over kind of a few things. You're going to talk about these way more in med-surg, because that's where the person would be if they were having these major effects. But they can get peripheral neuropathy or alcoholic myopathy. The one that we're going to talk about is a Wernicke's encephalopathy. So what this is this the most serious thiamine deficiency? So it's a thiamine deficiency. The person can get paralysis of their ocular muscles, stupor, death if thiamine is not replaced. Or it can lead into a more chronic state, which would be Korsakoff psychosis. So that's the next one that's listed there, is Korsakoff psychosis. Korsakoff psychosis is where the person has confusion, memory loss, confabulation. Anybody remember what confabulation is from fundamentals?
Storytelling.
Yeah, it's like making up memories. Yes, very good. Good job. And they need thiamine replacement, or it can be irreversible. So by the time it gets to a Korsakoff psychosis, then it might not be able to be reversed. So sometimes you'll hear this referred to as Wernicke-Korsakoff syndrome, because it's kind of like a spectrum almost. So this is why when patients come in, especially with alcohol use or abuse, they will often get IM thiamine. They'll get an injection of thiamine as they come in just to try to treat this and combat it from happening. Also, other effects on the body: sleep problems, sexual dysfunction, cirrhosis of the liver, esophageal varices. And so the cirrhosis, esophageal varices, I think you talk about in advanced med surge. Does anybody know what an esophageal varice is?
When your veins expand and they can get like bumpy feeling.
Yeah, so it's very similar to varicose. It's like a varicosity, a varicose vein. It's just that they're in the esophagus. So that means that they easily tear. And so the person can actually hemorrhage out through the esophagus. So not a good thing. Okay, going on to nursing process. So here we're going to go back to kind of general addiction. So not just alcohol, but kind of general addiction. And so there's a few like screening type questions that can be asked in the past. Have you drunk or used drugs more than you meant to? Have you felt like you wanted to cut down in the past year? But really there's lots of different questions. There's also something called the BDAST. So I think that there's an example of that, I think is in your textbook. But no matter what, the questions that we're asking, we have to make sure that we're non-judgmental. And I think it's better to kind of assume that everybody uses something when you're assessing. So can you tell me, how much alcohol you use? Can you tell me how much other street drugs, which ones? So it's very just matter of fact. And you make it very simple for the person to be able to answer those questions truthfully. The other thing that we watch out for is you need to watch the person's body language. So, and watch for like deliberate, rehearsed type of responses where you can tell they've been through this before. And so they just kind of say the things that they've rehearsed to say. And so they may not be truthful. I've had people tell me that they, drink a case of beer a night. And so, after work. And so you have to watch your facial expressions. So you're just neutral. You just write it down. Okay. Lab work. So we usually see urine toxicities, blood alcohol levels, and then they can do blood toxicities as well. But usually when they do a blood toxicity test, that's often for drugs that people overdose on regularly. So it isn't just street drugs. It's also things like TCAs. So those tricyclic antidepressants that people take, those are things that will show up. It's also acetaminophen, aspirin. So salicylate is aspirin. And what you'll see when you actually look at some of those results in the chart is that it will, if the person hasn't taken it, it'll pop up as abnormal because it's below therapeutic level. So I just want you to know that if somebody overdosed on something and they do a blood tox screen on them, and it shows that their acetaminophen level is low, that's not really abnormal. That's what we would expect if the person's not on something regularly that has acetaminophen in it. So does that make sense? Yeah? Okay, good. Excuse me. So we also see physiological changes. So when somebody uses regularly, they often have a very defensive style. It's very predictable. So you see a lot of the same types of behaviors. You'll see denial. You'll see rationalization. Those are extremely common defense mechanisms that you see in patients with addiction. We also see things like depression, anxiety, hopelessness, low self-esteem, and they can be very hesitant to work with a nurse because they think that they're going to get rejected. And so that's where we have to show that unconditional acceptance of our patients. That will help. or they can feel like a failure because, you know, they've fallen off the wagon type of thing. And so we have to let patients know that, unfortunately, I mean, it's expected that patients will start using again. Um, it, Especially if it's the first time that they've tried to stop. Okay, so we don't want them to, and we're going to do everything in our power to try to help, but slip ups do happen. So we want to make sure that after a patient has, you know, a slip up like that, we let them know that, okay, we're just going to start over, we're going to try again. Okay, I'm going to pause the recording real quick, and I will be right back. Sorry about that. So we were at then diagnosis. So the diagnoses that we're going to see are things like risk for suicide or injury or ineffective coping. Ineffective coping is a big one for most patients. Outcomes, we want to make sure they're free from injury, attending programs, that they can identify triggers. So that's a big thing that we do with patients with substance abuse issues, is we talk to them about, okay, what was going on when you decided that you needed to use this last time? What were triggers that were happening? And so if we can help patients see the triggers and their response to those triggers, then it can be extremely helpful, because they can try to avoid or minimize those triggers, or set up so that they have a different response to those triggers. They can try using different coping skills for that. Utilize support and new coping. So interventions, we need to build that trust. We need to accept the person for who they are. I don't have to like people's choices in order to treat them like a human being. We want to correct any misconceptions that they may have about, you know, the relationship. We don't want the patient, we want to help them not rationalize, not blame. Okay. We want to help them work on accepting the consequences of their own choices. We set limits, we work on coping. So that coping is a big thing, because most people are using drugs to cope with stress, or, you know, whatever the stressor is in their life. And so if we can help them come up with more positive ways to cope, we want them to replace the drug use, okay, with a more positive coping skill. So we can talk to them about, okay, what are the range of coping skills that you're willing to try or you're willing to use? And in different situations, which coping skill is going to work best for you? And so we kind of help them develop that plan. We want to show that positive reinforcement. So letting them know that we recognize that, you know, you're working on developing a plan, and you've talked to your landlord about the fact that you need to, you know, move out of there, and you're finding a new place because there's too much drug use around where you live, you know, and whatever that person is doing, we want to acknowledge it so that they continue down that right track. We also monitor for withdrawal and support them if they're going through withdrawal symptoms. We're going to talk about the different types of withdrawal, but some of them can be really, really difficult. Emphasize that self-responsibility. Nobody can make them use a drug, okay? That is up to them. They have the responsibility of choosing if they're going to use or not, deciding if they're going to change. That's up to them. Nobody else can make those decisions for them. Of course, we want to make sure that the person is safe, and a lot of the withdrawals can cause seizures. So a lot of times we have the patients on seizure precautions. We do things like reducing stimuli, providing for nutrition and fluids, giving them written information, because especially when somebody is withdrawing, or definitely if they're intoxicated, you know, they're not going to remember everything. So giving them written information, support them after the crisis. We have to make sure we don't react defensively. So sometimes patients can bring out defensive mechanisms in us, And so we really want to make sure that we're remaining neutral and supportive and are not reacting in a defensive fashion. One thing that helps me, because I've worked with a lot of patients with substance abuse issues, is to remember that it is a disease. It is that usually by the time that I'm working with the patient, that they actually have changed the chemistry in their brain. So it's not as easy to just say it's a choice anymore. They've done a lot of that damage to their brain and the chemistry in their brain to where they are truly dependent on these drugs in order to feel normal, in order to feel just about anything. Now that can reverse, but it takes a heck of a lot longer to reverse it than it does to create it, than it does to do the damage. So I just try to keep that in mind, that yes, this started out with some really poor choices, but it isn't just about choice anymore. We have to support them through the physiological part of it as well. And as I've mentioned about 100 times, we really want to make sure that they are learning about the consequences to their choices and actions. I have just a little note here that a substance abuse intervention, so it talks about this, I think there's just a little blurb in your textbook, but I do want you to understand that an actual intervention, like if you've seen the show Intervention and stuff, that has to be done with a specific counselor that is trained in substance abuse interventions. And it's all rehearsed with, like, the family rehearses it and everything, or the friends, whoever's creating this intervention. And then the key to it is that they need to have a place actually set up. So not just anybody can do an intervention, but you actually have a place that if you get the person to agree and say that yes, they will go inpatient somewhere, that it's already set up and somebody's ready and willing to take them. So that's what really makes a substance abuse intervention able to be successful. Okay, couple last things we'll take, and then we'll take a quick little break, and then we'll go over the chart here. So treatments in general, we want to make sure that they're detoxing safely, that they have some motivation for abstinence and recovery. And on page, on page 305, there's a chart specifically about pharmacotherapy and CNS depressants. And you do want to be familiar with that. I'll go through it here a little bit when we're looking at the other chart. But there's a lot of different types. Actually, let's just go through this real quick. There's a lot of different types of medications on here. So page 305 in the textbook, you have disulfiram. And this is the medication I was talking about, where it actually causes the patient to feel really sick when it's combined with alcohol, okay? So the person needs to be alcohol free for at least 14 days. That's important. And they need to understand that the severity of the reaction is going to depend on how much alcohol they're exposed to. And so what's really, really important with this is that the person has to be extremely compliant, and they need to understand that it isn't just ingested alcohol, it's any alcohol that they absorb, so even topically. So, or any alcohol if they get it in their mouth and they absorb it. So this means that they have to be careful about things like mouthwashes, going to the dentist, getting blood drawn when they do an alcohol, when they use alcohol swabs on the arm. So anything like that can cause a reaction in the patient. So we do want them to wear like an alert bracelet, okay? So that everybody knows that they shouldn't be exposed to alcohol, and then they have to be careful. If they go out to eat and there's, wine in the sauce, that can cause a reaction. So, and they can die if they start chugging some alcohol, they could actually die from it. So it needs to be somebody who is compliant. When we look at the next one, naltrexone, this blocks the effects of opiates. And so, again, this is when we just want to, have an idea of what naltrexone does. It's used quite a bit, okay? So it's going to help with alcohol cravings, but it also blocks the effects of opiates. So they should be opiate free for 7 to 10 days before they start taking this medication. Vivitrol or naltrexone extended release injectable is for alcohol abuse only. Okay, so even though it blocks the effects of opiates, it's not what it's used for. It definitely should not be used in somebody who has opiate dependence because it'll put them into withdrawal right away. Acamprosate or Camprol, I don't see this one as much anymore, so I'm not as concerned about it. It helps with withdrawal symptoms in alcohol. The weirdest thing about this is the dosage. So they have to take 666 milligrams 3 times a day. And do you know how many patients I had that refused to take this medication because of the dosage is 666? It's very bizarre, but yeah, but they just don't use that one as much. Now, one we see a lot is the Subutex or the buprenorphine hydrochloride, or Suboxone, which is the buprenorphine with the naloxone in it. So what's naloxone? Can't hear you, Jules.
Narcan.
Narcan. And what's Narcan do?
Blocks their opiate receptor
Yep.
or narcotic receptors.
Yeah, opiates. You're right, opiates. So thank you. It can, very good. It can reverse it can reverse opiates. So we use that in overdose and things. So what happens is buprenorphine is used for outpatient detox and maintenance. Now it does have to be given out by somebody who is specially trained. And when it is combined with naloxone, what happens is if the person goes to abuse it. So buprenorphine is actually, I believe it's actually like a benzo, or it acts like a benzo in the body. So what can happen is, we use it to help with withdrawal. So it's kind of like a substitution therapy, a little bit similar to like a methadone treatment, but it's used to, it's used as substitution. So the patient is not going to withdraw if they're on the buprenorphine. Now, patients will sometimes try to abuse that by crushing it up or trying to snort it or inject it or whatever they may try to do. When they crush up the Suboxone, so the one that has the naloxone in it, then it activates the naloxone, and so they won't be able to get the effects of the opiate. Does that make sense? Okay, so it activates it when they go to abuse it.
But when patients come in with, when they come in with substance abuse and like they're an alcoholic, do doctors like often bring these meds up? Like, do you know what I'm saying? Like, give this as like an option for them. Like, hey, if you stay clean for, the 7 to 14 days or whatever it is, we can put you on this med that'll help you, like, you know what I mean?
Yeah. A lot of times some of these things are brought up while they're inpatient. Sometimes we'll have patients who are already on them when they come in. So especially the ones that are like methadone and Suboxone, the ones that are really regulated like that, where you have to have specially trained physicians, the psychiatrists aren't always the ones that will prescribe those, but they can help them get linked up, or when they go out into the community mental health centers, then they can help them get linked up with specially trained doctors. But I have seen Camprol a while ago, and disulfiram for sure, that they'll get started on even while they're in the hospital.
Okay. Yeah,
Okay.
that's cool. I've never heard of these drugs, so I didn't know.
Yeah. Yeah, they're in very specific populations. These are used. Okay, so go back to the treatment, AANA. So these are support groups. They can use 12 steps as, did you guys shared your AA? Somebody had online AA stuff that they were going to share in your Facebook page. Is that right? No? Yes?
Yes, I did. I have it. I completely forgot about sharing it. I will send it out today.
Okay, thank you. So
Uh-huh.
that way people can do that. And because I imagine it might be the same one that I have, but I think mine's geared more towards Toledo. But let me, I'm going to write myself a note. I forgot to. I will do that. I have 1,000 pens in here. And so those can be, as we mentioned before, 12-step programs. They can use the big book, but there's all kinds of different things that the different AA groups might do. There's also Al-Anon, Alateen. So Al-Anon is for friends and family of someone who uses substances, and then Alateen is for teenagers, children of those that use alcohol or drugs, I think. These help to avoid enabling. So these will help the family and friends avoid enabling, help them understand the disease. So it's education. Counseling can help. It can be one-to-one, or then there's group therapy below that. But it usually helps them accept that the substance is actually causing a lot of the problems in their life. And they can help the client decide that they do want to change. So it'll work with the client to help them regain control and abstain from use. And then group therapy, they can share experiences and helps communicate needs and feelings directly. So a lot of times, people that use drugs, or people in general that make poor choices, often don't know how to communicate what their needs are to other people. And so they cover them up or hide them or whatever, use drugs. So if we can help people learn how to communicate better, that can just be helpful in their life in general and help them stop using the drugs. Dual diagnosis. So I think I mentioned this the very first day, but dual diagnosis is very specific to a mental illness and a substance abuse issue. So like depression and alcohol abuse. So programs can be found inpatient or outpatient, but they're going to target both issues at the same time. So dual diagnosis went through evolution where, at one point in time, they decided that you needed to treat the drug use and that would help the mental health problem. And then another point in time, it decided that you needed to treat the mental health problem and that would cure the drug use. They figured out that both things, they're usually more intertwined and you have to treat them both. So they tend to take a more supportive, less confrontational approach than with general substance disorder treatments. So they have a lot of empathy, help with hopefulness, and they work as a team to help both issues with the client. In general, we help encourage 12-step programs or support groups. AA is actually research shown to be the #1 way to help clients abstain from alcohol. Okay, so AA is a huge benefit to patients if we can make sure that they find one that they like. And that's a big point for patients, is that you may not click with a certain group, but don't stop there. Try again. Try a different one. Maybe you prefer one where you get to be quiet and just listen to others. Or maybe you prefer one where it's a small group and you talk, but you need to try to encourage those. And that there are some of those that are more specific to patients with mental illness. So they may want to do one of those. Now, the last thing I'm going to say before we take a quick break, okay, is that, there are times where you might not be super comfortable as a student talking to someone with substance abuse issues and doing something that we call supportive confrontation, okay? But as a nurse, that's one of the things that we have to do. And so a supportive confrontation is when somebody comes in, and I've had to do this so many times. Somebody comes in and let's say they were just there. And I have a female, and she's in her 20s. She's got 2 little kids, and they keep getting taken away from her because she can't stay off drugs. So I might talk to her the next time she comes in and say, okay, you say you want your kids back, but within 24 hours of you being discharged, you're using drugs again. We need to talk about that, because your actions they're not helping you reach your goal. And so you say it's neutral, but you are confronting the person. You are letting them know that these things don't match up. What you want and what you're doing, they're not the same thing. And so we help patients kind of think about those consequences and how we can help them change some of their behaviors. So just kind of a side note there on how we approach patients sometimes. Okay, let's take about 5 minutes or so, and then we'll come back and go through the chart. Okay, you guys doing okay? I paused the recording, but okay, good deal. All right, I'll be right back. Was it good? Good. Sorry, puppy. So Deb, did you pick up extra time or something since we're not in class?
Yeah, normally like on Mondays, I would come in and work until like 10:30 and then leave, go to class, and then come back to work. And then Tuesdays I would be my late days. So it's kind of nice. I can go back to like an 8 to 4 shift, but I can just do this from my office. So it's hard to get used to, but I'm trying to manage it.
Yeah. You mean the videos or the like learning this way? You mean it's hard to get used to?
No, I'm doing okay with this. It's just like getting everybody else on board, because like they keep paging me, and like I'm on do not disturb, but they keep trying. So if they can't call through on my phone, they're intercomming me on the overhead. And then we had an STR meeting that I just learned that it was at 9:30, and I'm like, nobody invited. I never got an invite. I never got any notifications, so I can't be at that meeting. So it's all right. They'll let me know what happens. But everybody's doing these Zoom meetings now. We're doing them at work.
Yeah. And I have
yeah.
a co-chair of the learning assessment committee for the college. So we're going to try to set up a Zoom meeting. We're supposed to meet today. We're just going to do it via email and then try to set up a Zoom meeting for next month.
This is kind of cool. I think it's like they started like a new way of, even after all this is over, I think I like this better because every week I have to go to Detroit, or I have to go up to, Washington CMH a lot. So if we can do this.
Yeah, I would say I'm driving a lot for sure.
Absolutely.
My daughter just got done with her meeting. I don't know. It wasn't on Zoom. It was like Google Classrooms or I don't know, something like that.
Oh, okay. Yeah.
She just had her virtual meeting too. So she was excited about that. Just getting to see some of her classmates and friends.
Right. I know mine are going stir crazy. They're going crazy at home.
Lily's doing a lot better than I thought, actually. I think
Yeah.
it helps that she's an only child and she's kind of used to doing her own thing.
Yeah.
Mondays are my longer day, like of work. Like I have office hours and I have a lot going on Mondays trying to get everything ready. So she gets she was a little emotional yesterday because I wasn't around a whole lot. But other than that, yeah, we try to do an activity or something each day, and she's got her list of things she has to accomplish, so we're working through that. We're gonna paint eggs today.
Are you? That's cool.
Like I have little paper mache eggs I bought, so we're gonna paint those so we can decorate the house with them. So it should be fun.
That's cool. That'll be fun. Something, creative and
The weekend we paint taped the front door. We just have like a clear outside door, and so we taped it, and then she painted it with some washable tempera paints.
Oh,
and
how cool.
like stained glass.
Oh, that's cool. So it's almost like you don't want to take it down, like you want it to stay like that.
Yeah, we'll keep it like that all spring. Maybe
Right.
I'll see how long it lasts, but it looks like it's really cool. So you walk by the house and it looks like a door.
Stands out. That's super cool. That's a good idea.
I saw it on a Facebook page for Sylvania, so a lot of kids were doing that, like an art project or a front window. We have friends that did their front window that way.
Mm-hmm.
So.
My kids, when they were little, I would let them they had like the window markers. So they would always, like my windows were always drawn on. They were, my refrigerator, but I mean, it's washable, so it's no big deal.
Right.
They loved it.
Looks like we'll wait just one more minute. Got just a couple people missing from their picture here. So,
Nicole, I do have a question.
Mm-hmm.
So one of our mat services that we provide is Vivitrol, and we use it for alcohol and opiate.
Yeah. The big thing is that you have to know that if somebody is using it and they are on opiates, it can cause instant withdrawal.
Right.
So it's not that I think that it's completely contraindicated. It's that you can't have it, definitely can't use it when somebody's supposed to be on opiates for like pain management or whatever.
Right.
Because it reverses it, kind of. It'll cause the withdrawal symptoms right away. So.
Absolutely. But I thought you said that the injectable is not for alcohol.
Your textbook says that it's not for opiates. It says it's for alcohol only.
Okay.
Okay.
All right.
Not to say that people don't use it off label, for other things, but I think that's what it's approved for. Gotcha. Okay, it looks like everybody's back. So I'll go ahead, I'll start recording. We're going to be in the table, okay? Oh, it looks like I was recording all of that. Awesome. Okay. Well, that's fun. I'll see if I can figure out how to fix it. But So the drug categories here. So we have opiates, and of course, you know, things like morphine, codeine, heroin. Those are all, you know, issues with, those are all different types of opiates. So I try to have things kind of highlighted a little bit for you. And then there's some blank areas. We're gonna go over what goes in the blank areas here, but this is really information from your textbook. So I pulled information from your textbook as well as your ATI book. So the ATI book has a nice table with all of these things in it. I apologize, I'm not gonna start with opiates. I'm gonna start with your CNS depressants, okay? So the CNS depressants are your anxiolytics, so things like your benzodiazepines, barbiturates, alcohol, and then other sedatives. So what we can see when somebody is intoxicated with a CNS depressant, you want to try to look to see if there's some things that are a little bit different than the other ones, because a lot of the signs and symptoms can be similar. So you want to know the differences. So aggressiveness, impaired judgment, slurred speech, nystagmus. Do you remember what nystagmus is? Anybody remember? Yep.
Like the eyes twitching.
Yeah, it's the twitching, and so it's the oscillating from side to side. So if it's what they are checking for when they have, you know, you follow the finger and then you go this way and you go this way, and you want, it should be a nice smooth movement. But if somebody's intoxicated with a CNS depressant, it causes cranial nerve issues, and so the eye will kind of go like this as it moves across, you know, from side to side. So those are things that we look for. Now, of course, we know overdose signs and symptoms, and then there's some information on treatment, but you know, shallow respirations, we know that CNS depressants cause respiratory depression, right? You know that. So keep that in mind, that the person can die, they can go into a coma. I don't know. I used to work down by BGSU in the ER as a tech, and you don't know how many 21st birthdays people got intubated, okay? So it's definitely a real thing. And then when we want to look at treatments, I believe we're going to look at page 303. So of course, maintaining their airway is extremely important. Keeping them awake, you might have to induce vomiting. So if you look at possible overdose treatments, activated charcoal can help. Vital signs, they may need, as I said, they may need intubated. Definitely IV fluids. There's actually certain IV fluids that can be given that will help replace the vitamins and things that the person has been missing. They call it a banana bag. It's yellow. They can do gastric lavage as well, which is where they actually like put fluid in and then take it out and try to kind of cleanse the system of the drug. Again, we have to watch for vital signs. Seizure precautions are very important. And then if it was extreme cases, dialysis might need to be done. Now, there is a medication that I want you to make sure that you have listed under treatment, and that is flumazenil or Romazicon. So it's FLUMAZENIL. And again, that's on page 303. And that is specific to benzodiazepine. So it's like a benzo reversal agent or an antidote. Okay, so specific to benzos. Now, under withdrawal, symptoms and treatment. So the patient can have tremors, they can have seizures, they can have hallucinations, especially if you start getting into like a delirium tremens type of thing, DTs. And so we need to understand that the patient can really, can have like a mild withdrawal, or with alcohol, it can be extremely severe. With benzos, it can be extremely severe as well. So when we look at treatments, there are different substitution therapies that I mentioned. So there's the Suboxone, there's methadone. Those are substitution type treatments. We also use something called a CIWA scale, C-I-W-A, and I can't remember what it stands for. We just call it the CIWA scale. If anybody knows what it stands for, go ahead and chime in. I'm fine with that. Do you know what it stands for, Deb?
I think that's
clinic-
the one for the
clinical-
alcohol. Sorry.
Nope, go
That's
ahead.
okay.
Yeah, I think that's the one from when you have patient that's alcoholic, like they use that for what do you call that? Like that's their
It's the Clinical Institute Withdrawal
Yeah.
Assessment.
Thank you. Clinical Institute Withdrawal Assessment. So what it is, because I have used it, I just couldn't remember the actual name of it. But what it is you're it has like signs and symptoms that the patient is experiencing, and then it has like titrated treatments for it. So it would give you which medication that you would be using. So a lot of times they might use Ativan, which is lorazepam, or they might use Librium, which is chlordiazepoxide. And both of those are listed on your chart, so you don't have to try to spell them. They're both there. They're just over under comments. So they would tell you how much of that medication that you would give based on how bad the withdrawal symptoms that the patient is experiencing are. Does that make sense? So it's a really good scale, an assessment scale and treatment scale. So also on page 304, it talks about the alcohol withdrawal delirium. And I know you guys put that in your on your advanced organizer. So do make sure that you have reviewed that as well. So things like anticonvulsant, seizure precautions, substitution therapies, multivitamins, vitamin B1, which is thiamine, folate. Folate is another one that we give patients to just help with. What happens is especially with alcohol, patients will just drink all their calories, and so they tend to be full, and they don't eat, and so they really end up rather malnourished. So it is important that we help to replace some of those really important, like vitamins, minerals type of thing. Okay, when we look under comments, so alcohol withdrawal can begin within 4 to 12 hours after the last drink, and can progress into DTs or delirium tremens on the second or third day. So that's just kind of how typically it goes. So we have to ask patients if they're known to use quite a lot of alcohol. We need to ask them if they've ever had seizures when they withdraw in the past, or if they've ever experienced DTs where they can actually go into hallucinations. And it is a delirium state, so in which they can seize and potentially die. So we need to find that out, because then we need to watch that person much closer. We need to make sure their substitution therapy is really up and closely monitored. So like I said, we use Librium or chlordiazepoxide or Ativan for types of substitution therapy.
That's why liquor stores are considered essential right now.
It might be, I don't know.
Legit, it is. Mm-hmm. Because like people can come in and we've intubated before because they're withdrawing so bad.
Yeah.
Because everybody's like, why are liquor stores open? Well, because alcoholics withdraw, and then they're really fucked. Oops,
Yeah.
sorry, messed up.
So I have actually seen like alcohol be ordered for patients. Now again, a long time ago when I was on the floor as an aide, but and I wasn't allowed to give it to him because I was only 16, but they would actually give the person like a beer or whatever. It was quite interesting.
And people go on alcohol drip for antifreezes when they ingest antifreeze.
Yep, it's in a glass vial, isn't it? Glass bottle. Yeah, we used to keep a bottle of alcohol for somebody who overdosed on antifreeze. Okay, so under comments, it's withdrawal may progress to delirium, usually within a week. Long-acting barbiturates may also be used. Okay, so CNS stimulants, we have amphetamines, cocaine, and then other ones that are not quite as worried about. So when somebody is on these, they usually are euphoric, grandiose. They tend to fight, elevated vital signs. And so what we can see when they overdose are cardiac arrhythmias, headache, again, convulsions, hypertension, rapid heart rate, coma, death. Cocaine specifically, we can see more hallucinations, pulmonary edema, respiratory failure. Okay. So they can have cardiac arrest. They tend to also get hyperpyrexia. So our treatments then go along with what are some of the things that we're seeing. So they should be on a cardiac monitor. Makes sense, right? We need to be assessing their respiratory status, especially with cocaine. Definitely safety, because they can get, want to fight and stuff. Seizure precautions. Measures to cool the patient. They may need an antipsychotic medication. And remember that when we give antipsychotics IM, those are usually, acute, and they will help not just the hallucinations of things, but they do help to calm the patient too. And then we might have to sedate them with like a benzodiazepine. And then specifically for amphetamines, they might give ammonium chloride to help acidify the urine, which helps to pull that amphetamine out of the body. And so you should be able to see these things on page 307 as well. Okay, when we look at withdrawal symptoms and treatment, so we can see the person can have anxiety, depression, issues with sleep, and then especially with amphetamines and cocaine, they can have suicidal ideations. So that's really important for the treatments. They can have a dopamine agonist. We want to make sure that they're on suicide precautions, okay, especially if it's cocaine or amphetamines. And then because they can have that anxiety or issues with sleep, we want to decrease stimuli, help them regulate their sleep, ensure that they have food, and then help manage their depression. And of course, suicidal thoughts. But they may need to be on an antidepressant. So comments, withdrawal symptoms usually peak in 2 to 4 days, but depression and irritability can last for months, okay? So that's why they may need to be on an antidepressant. Antidepressants can help with irritability too. Okay, inhalants. So inhalants are pretty much anything that people can get their hands on, okay? So anything that's can be aerosolized, paint thinner, I mean, just about anything. Household items can be used as inhalants. And so what's important to know that when somebody is intoxicated with this, they can get belligerent, assaultive, or they can be completely apathetic. It depresses their reflexes, tremors, blurred vision, coma, death. You might see irritation around the eyes from the chemical that they're using, or irritation around the throat and the nose, because a lot of times they cover their face to make sure that, you know, they're getting a more concentrated dose of whatever they're inhaling. So when we look at overdose, they can die from CNS depressant, from cardiac arrhythmia, respiratory arrest, suffocate themselves. I mean, these are really bad. And kids, teenagers often do this because they have easy access to this stuff. And they can die from the very first time that they use it. And a lot of times they don't understand that. So there's not a whole lot of like real specific treatments for this. A lot of it's just supportive treatments in nature. So you can see this on page 311. But it's mostly, you know, support the system that is affected. So a lot of times it's respiratory system. So they might need to be on oxygen. They may also need cardiac monitoring. Vitamin B12 is thought to help their neurological status. So they may give that as well as folate. They may need some Zofran. I don't remember the generic name for Zofran, but they may need some Zofran. If you know it, go ahead and say it. You're good, Deb. Or Jules.
Ondansetron?
I can't remember.
OND, ondansetron.
Ondansetron.
Thank you.
Do you want me to go get my OTCs, my OTDs?
ODTs? ODT?
We need to watch for suicidal ideation, safety for sure. And then because these people can get like belligerent, we often use haloperidol or Haldol, IM. So haloperidol is a typical antipsychotic. So it's one of the older medications, but it is used for people who are assaulted, belligerent, violent. It's used a lot in that population. And then we want to make sure they're getting plenty of fluids and we're monitoring their vital signs. Okay, for comments under there, so intoxication usually occurs within 5 minutes and they can last, the symptoms can last for 60, 90 seconds. So this isn't like a long-term thing. So people do it over and over. And large doses can result in death. Okay, we doing okay? Mm-hmm. Okay. Opiates. So now we're going to get to opiates. Opium, of course, morphine, codeine, heroin, intoxication symptoms. So slurred speech, euphoria, but also constipation, decreased respiratory rate and blood pressure, and pupil constriction. So those are the things that we tend to see. I think these are on page 306. Yes. So overdose, you see that shallow breathing, pulmonary edema, respiratory arrest, convulsions, and the person can actually end up with dilated pupils if they're hypoxic. If they're, nope, I think I said that wrong. No, they can end up with pupil dilation. So the treatment is generally the naloxone. Yeah, I said that right. Okay, pupil dilation as a result of hypoxia. So usually with treatments, we use that Narcan to help reverse the agent. Just keep in mind that the half-life of naloxone or Narcan is shorter than the half-life of a lot of opiates. So the person, you know, you can have an overdosed patient, give them naloxone, kind of bring them out of that overdose, and then they can go back into the overdose when the naloxone wears off. So those patients really should be monitored after a dose is given. Okay. Definitely respiratory care, vital signs, seizure precautions. You know, those are all things that we need to make sure that we take. Withdrawal symptoms, so some really interesting withdrawal type symptoms that you see with opiates. What I can tell you is that patients who withdraw from opiates, I don't know how many have told me that they just wish they were dead. And it's not that they have suicidal ideations, it's that they are so miserable from the withdrawal. Okay. So we have to keep that in mind. They're having all kinds of muscle aches, nausea, vomiting, lacrimation, which is tearing, rhinorrhea, runny nose, piloerection, which is like goosebumps, sweating, diarrhea, yawning, which is a really interesting one, fever, insomnia, suicidal ideations. So they're literally just miserable. Okay. So the treatments, the substitution therapies, like I said, with the methadone or the Suboxone, those can be really helpful in withdrawal. Another thing that we use sometimes with opiates, also we use it with alcohol too, is clonidine, which is an actual, or it's also called Catapres, so it's a blood pressure medication. And so that helps in treatment quite often as well. Then we do symptomatic treatment. So the person may get things to help with their muscle aches, to help with diarrhea, vomiting, so just medications to help with those things. They're on suicide precautions, especially if they're having suicidal ideations, and plenty of fluids. So under comments, the withdrawal symptoms usually appear within 6 to 8 hours after the last dose, reach the peak in about 2 or 3 days, subside in about 5 or 10 days. So the person may be miserable for quite a little while. There is a typo on here. So not deadly in withdrawal, but very sick. Not deadly in withdraw. Anything's deadly in overdose, okay? So it should say in withdrawal, but very sick. Hallucinogens. So there's several different ones here. These are on page 10. I kind of combined some of the hallucinogens and the dissociative drugs together, okay? So you'll see, again, belligerence, assaultiveness. Those are big with these medications. I mean, this is huge, the assaultiveness. They have a diminished pain response. That's really important to know, especially with the dissociative drugs like the PCP. They tend to be very labile, so their mood's all over the place. And then they can have synesthesia. Anybody know what that is? Synesthesia?
Their senses.
When they can like feel the colors or see the sounds.
Yep, where their senses are really like they're mixed up and they might be able to see sounds, hear colors. Yes. Okay, so in overdose, you're going to see that agitation or violence, hallucination, psychosis, convulsions, hyperpyrexia. They can die, okay? So the big thing here is the hyperpyrexia and the violence, as well as, convulsions. The patient, they can always convulse and stuff too. So your treatments here, you want to watch their cardiac, any cardiac symptoms we want to make sure that we're treating. Acidifying the urine can help again here. So generally when somebody starts to get agitated, irritable, like we try to talk the patient down, and we'll talk about that later when we talk about anger and aggression. These are not patients that you ever want to try to talk down, okay? Especially somebody on PCP. You do not try to talk down a patient with PCP. And I'm going to give you a quick story about that. They can be so violent and their pain response is so diminished that they seem like superhuman. They're like invincible, okay? So you have to be extremely careful with these patients. And other medications we might give, again, antipsychotics or benzodiazepines to try to calm, settle the patient down, decrease their violence. definitely on seizure precautions, vital signs. We may need to try to cool the patient, and safety. So we had a patient come in on PCP when I was working nights in the ER as a tech, and we would get them, the ambulance would radio in, and so we got a report that we were getting a bloody naked guy. Okay, that was the report, bloody naked guy. And so the police came in. He's handcuffed, face down on a backboard, and there's a bunch of police officers with him. Well, he was on PCP, and what he thought, he had hyperpyrexia, so he was so hot that he stripped naked and thought he was burning in hell. So he's running around a parking lot on campus with all the, these police officers get called and they come over. Well, he beats up a bunch of the police officers. So it took multiple, I think we saw 4 or 5 in the ER police officers needed treatment. So it took so many different police officers to like tackle the guy and get him to calm down. And he was like separating everybody out, and he thought some people were angels and some people were devils. And it was just a very, very interesting night. And he was all bloodied up from the scuffles, and they just had like a blanket wrapped around him. So looked like he was wearing a diaper. And so when he came in, and luckily he thought I was an angel. He thought the doctor was the devil. And so he would talk to me a little bit. But I mean, just the looks on people's faces when they are actively on either dissociative or hallucinogen it's extremely different. I don't really know how to explain it, except that they're not in contact with reality at that point. And they just have a very different expression, and you have to be so careful. Okay, so the withdrawal symptoms, there really isn't a withdrawal with hallucinogens. Comments, delirium can happen within 24 hours after the use of PCP and can occur up to a week following recovery from an overdose. So they can kind of relapse into these delirium states. Okay, last one is cannabis. So we know that cannabis is being used more and more recreationally, that it's legal in a lot of places now. And so the big thing here is that we are starting to see more people with intoxication with cannabis, because the grade of cannabis that people are getting their hands on is much higher grade. It's medical, marijuana that people are using. And so you do see people with paranoia, suspiciousness, definitely increased appetite goes along with it, hallucinations. And cannabis used to actually be categorized as a hallucinogen. So it does have those properties with it. So just keep that in mind. They kind of made it its own category now, but it does have some mild hallucinogenic properties, especially the stronger that it is. It can also cause depression. When we look at overdose, so people can become extremely paranoid, delusional, psychotic type things when somebody's on a lot of marijuana. And so for the most part, it's just symptomatic. It's safety, it's antipsychotic medication, lower stimuli, safe environment type of treatment. If higher doses are used for a long period of time, then they can kind of have a withdrawal type of syndrome with it, but really it's just symptomatic treatment. So if they're having trouble sleeping, then you might help, they might get an antidepressant or something to help them sleep, resting, that type of thing. So nothing really specific there. Comments, intoxication usually occurs immediately, lasts about 3 hours. Oral ingestion is slower, has longer lasting effects. What can happen though, if somebody uses marijuana on a regular basis, they can end up with amotivational syndrome, which is where, and that's kind of the classic, thing that you think of with somebody that uses marijuana on a regular basis, that they don't really want to do anything, right? So that's kind of what that is. And then they can end up with persistent cognitive symptoms and decreased IQ. So it can have permanent damage to the patient, to the person. And so that's why it's really important that kids aren't, teenagers and stuff, while they're still developing, are using marijuana, because it can cause that permanent damage. The other thing that I don't have listed on here, but we'll talk about it next week with schizophrenia, is that they do see that a lot of onset of schizophrenia, especially in teenage or younger males, happens with marijuana use. So there is some thought that marijuana use can trigger schizophrenia in those who are already susceptible. So, okay, did we cover everything, or did I? Trying to see if I missed anything. I think I did. Did I miss the nursing considerations on the other page? Back to page 72. We just didn't go over the end piece, so let me do that real quick. So nursing considerations, so page 72 in your course pack. We want to make sure that we're building trust, that we can role play to help address issues, that we help them understand how their problems affect other people, relapse education, monitor for withdrawal, teach that recovery is long-term, and that unfortunately relapse does happen sometimes. Evaluation overall, are they free of the substance? Did they detox okay? Are they accepting responsibility? Nutrition restored? They have other coping mechanisms, and that we need to remember that we need to keep helping. So even if we've gone through this before with this patient, we still continue to help. Okay. All right, I really hope that I recorded this